I am Sung-Min Park from the Department of Orthopedic Surgery at Seoul National University Bundang Hospital. Today, I will be presenting about navigation-assisted endoscopic surgery. This technique is becoming increasingly important in the field of minimally invasive spine surgery, and I would like to share with you both the advantages and limitations along with some of our experience. Navigation provides surgeons with real-time intraoperative guidance, improving accuracy and safety. In minimally invasive surgery, where the field of view is often limited, this guidance plays a critical role. Navigation is now considered an essential technology that supports both clinical outcomes and surgeon confidence. One of the most common navigation tools is the CT-based navigation system. In this system, intraoperative CT imaging is performed during surgery. The images are then reconstructed and used to guide the surgeon in real time with three-dimensional visualization. This combination allows us to perform highly precise procedures, especially in complex spinal surgeries. The first key advantage is accuracy. Compared to conventional methods, CT-based navigation significantly improves the precision of pedicle screw placement. We have real-time 3D visualization, which reduces the chance of misplacement and makes the overall procedure safer. This improvement in accuracy directly translates into better surgical outcomes and lower complication rates. Looking at the data, we can see the benefits clearly. In the navigation group, the overall breach rate was 11.3%, compared to 22.2% in the control group. When we focus on major breaches, the difference is even more striking: 1.5% with navigation versus 4.4% without it. This demonstrates that navigation provides a significant reduction in errors, regardless of the specific platform used. Another major advantage is reduced radiation exposure. Traditionally, spine surgeries require frequent use of fluoroscopy, which exposes both the patient and the surgical team to radiation. With navigation, the exposure is minimized. For example, by standing more than 2 meters away from the isocenter during intraoperative CT, the surgical team can avoid excessive radiation. This is a clear benefit for both the patient and the staff. Navigation also contributes to faster recovery. Because it enhances visualization through a smaller incision, we can avoid excessive dissection of tissues and reduce the risk of injury to critical structures such as nerves and blood vessels. Furthermore, navigation can be integrated with robotics, which significantly improves the accuracy of pedicle screw placement. This combination is particularly promising for the future of minimally invasive spine surgery. However, navigation is not without disadvantages. First, there is an issue of operation time. While the actual surgical procedure time may not differ significantly, the preparation time is usually longer when setting up the navigation system. This can be a challenge, especially in urgent or emergency cases. Another limitation is cost. The navigation system, including the O-arm, is expensive, and it requires a larger operating room to accommodate all the equipment. There are also potential internal errors in the system, with small but measurable deviations. And, importantly, there is a learning curve. Both surgeons and nurses must become familiar with the setup and workflow, which takes time and training. Despite these challenges, navigation shows very promising results in endoscopic procedures, such as PELD, percutaneous endoscopic lumbar discectomy. Studies have shown that with navigation, the average operation time is shorter, the number of puncture attempts is significantly reduced, and the first puncture success rate is much higher compared to conventional methods. This is especially valuable in cases where precision is critical. Here, I will share a clinical case. This was an 82-year-old male patient with weakness and radiating pain to the lower extremities. He had a history of previous surgery, PLIF at L4-5S1, 5 years ago. In this case, navigation-assisted techniques were applied to improve accuracy and minimize risks, which is particularly important in revision surgeries and elderly patients. In the operating room, several key components are required for navigation-assisted endoscopic surgery. These include the O-arm, the navigation system itself, the patient tracking devices, the dynamic reference frame, and, of course, the endoscopic tower. All of these must be carefully integrated and positioned to provide accurate, real-time guidance throughout the procedure. In open surgery, the reference frame is usually attached to the spinous process. However, when we perform PPF or endoscopic surgery, it should be fixed to the iliac crest, especially the PSIS area. There are dedicated devices that can be inserted easily with a mallet, so fixation is generally not difficult. When placing the reference frame on the PSIS, it is better to insert the pin from inferior to superior. This way, the surgeon's hand is less likely to be obstructed during the procedure. However, in lower-level surgeries, the instruments can still interfere, so as you can see in the right image, using an extension device is helpful. I recommend positioning the navigation unit distal to the scope tower. If it is located near the anesthesiology area, the equipment may obstruct the view of the iliac crest reference frame. Once the frame is fixed, we proceed to take the O-arm scan to register the anatomy accurately. After setting the frame, we first check the spinal level and then perform the O-arm scan. This generates CT images in real time, as shown on the right, which are immediately available for navigation. This provides us with precise anatomical information before starting the decompression or discectomy. Next, we set up the instruments. Unlike pedicle screw fixation, navigation-assisted endoscopic surgery does not require many specialized instruments. In fact, apart from the screw set, all we need are universal adapters for the probe and burr. On the left, you can see the navigation probe, which is used to identify the laminectomy site and confirm disc location. On the right, the burr system is shown with a universal frame attached. This allows us to track the exact position of the burr tip during bone work. Before starting, we need to calibrate the universal device. This is done by tagging the probe and burr to the reference frame so that the navigation system can recognize their position accurately. Once calibration is complete, we are ready to proceed. After instrument calibration, we determine the portal site. This is done using the navigation probe. We check the planned laminectomy area, identify the ideal entry point, and then make a small incision at that location. We then reintroduce the probe to confirm that the incision is correctly aligned with the target. As shown in this video sequence, we insert the probe and move it slightly to test different positions. The goal is to find the most appropriate trajectory for the portal. This step is crucial because a well-placed portal allows for easier access and safer decompression. After making the incision, we once again probe the laminectomy site to confirm accuracy. This ensures that the portal is correctly aligned with the navigation plan, minimizing unnecessary dissection or reincision. Finally, we begin the laminectomy using the burr. Throughout the procedure, the navigation system provides real-time feedback, showing us the exact location of the burr tip. This allows for precise bone removal while protecting surrounding neural and vascular structures. It is one of the most important benefits of combining navigation with endoscopic techniques. Here, you can see the laminotomy from another angle. Sometimes, during surgery, it can be confusing to identify the exact part of the lamina being removed. With the navigation system, we can continuously confirm the precise location, which greatly improves both accuracy and confidence during the procedure. When working on the inner cortex, we can use the probe to verify our progress. On the navigation monitor, you can see that the probe tip directly contacts the inner cortex. This real-time confirmation allows us to safely continue the decompression without unnecessary removal of bone. Once the laminectomy is nearly complete, it is important to confirm that both the ipsilateral and contralateral sides have been adequately decompressed. By using the probe, we can palpate both edges and check the navigation images at the same time. This ensures that decompression has been sufficiently carried out across the full width of the canal. Navigation is particularly useful when checking the contralateral foramen. For example, at the L3-4 level, not only can we assess the superior articular process of the L3 foramen, but we can also partially visualize the L4 foramen. This helps confirm that the foramenal decompression is complete and reduces the risk of residual stenosis. Here, you can see the post-operative MRI images. They clearly demonstrate that decompression has been successfully achieved on both the ipsilateral and contralateral sides. This confirms that the navigation-assisted approach allowed us to perform precise and effective decompression throughout the spinal canal. To conclude, navigation-assisted endoscopic surgery offers several key benefits. It allows for greater accuracy and safety, making procedures more reliable. It is particularly advantageous for beginners, for complex or narrow surgical approaches, and in procedures that typically require frequent use of the C-arm, such as PELD. While it may provide only modest additional benefits for biportal endoscopy, it remains a valuable tool whenever the necessary equipment is available. Overall, navigation is a promising technology that supports more precise, safer, and reproducible outcomes in endoscopic spine surgery. Thank you very much for your attention. I hope this presentation has provided useful insights into the role of navigation in endoscopic spine surgery. I would be happy to take any questions or hear your comments.